my plan is to go into a bit more detail about sepsis, to just briefly go through some of the anaesthetic deaths, very briefly touch on hemorrhage, but I'm not going to say much about that, and then a bit more about 10 recommendations, but not very much because he's covered that really. So sepsis, as he's said, it's the leading cause of direct death, and it's the first time this has been so for a while, certainly in the last few inquiries. And there are 29 genital tract sepsis. They're put in the 3 late ones as well, but they were really involved with the pregnancy, but just the deaths happened late because they had been ventilated on ITU with multi-organ failure for some time, so they died after 30 days of delivery, but they were really related to pregnancy, so they've been included in this chapter. And I'm going to talk a bit more about the rise in group A strep. And that is because when we went to the launch in Manchester, there was a little group of anaesthetists sitting there going, exactly what is group A strep? We were just a little bit confused. So I thought I probably wasn't the only one who was confused. So I'm just going to tell you a bit about the old strep. So here you are, your big streptococcus. And there are 3 different sorts: alpha hemolytic, beta hemolytic, and gamma hemolytic. And we're interested in this one here, which is group A strep. This is group B strep, which is the one that causes neonatal deaths, and we give antibiotics to pregnant women on, but it's obviously it's a different bug. We've also got pneumococcus over here, strep viridans, and strep bucalis. And the group A strep is interesting. It's community acquired. It's pretty much endemic out in the community, and it's one of the commonest causes of bacterial sore throat in children. Obviously, the commonest cause is still viral for a sore throat, but if it's bacteria, it's likely to be strep A, group A strep. It can cause other bad things. This is what I did vaguely remember. It can cause scarlet fever, rheumatic fever, necrotizing fasciitis, and various other things like that. And it's because it's a bacteria that produces a toxin, and that's why it kills so rapidly. And it is a cause of peripheral sepsis, which again we nodded at. Thought, I wonder exactly what peripheral sepsis is. So this is the World Health Organization definition of peripheral sepsis. It's infection of the genital tract any time between rupture of membranes or labour and 42 postpartum days, with 2 or more of the following. They are looking a bit at reviewing this definition for the sake of the inquiry. This is a World Health Organization definition, and so it applies to the whole world. And clearly these are 5 things that are easy to pick up in most health systems, whereas we can be a bit more technical and talk about CRPs and things like that. So there is a bit more of a technical chapter on it, but essentially that's what peripheral sepsis is. Now, what really shocked me about this chapter when I went to the launch was how rapid the deterioration of these young women were. And of course, I'm an anaesthetist, and I've worked a lot on ITU, and I do see young people getting very sick very quickly. But there's something particularly tragic about some of the vignettes here. And 7 were previously fit and well, had had normal vaginal deliveries. They were the sort of person you'd think nothing of, and sent home, and that'd be fine. And then a few days later, they're dead. And one of them died of mastitis, which just seems so Victorian, you can't quite believe it, but it's true. And sickle cell was raised as a risk factor. 3 of these deaths had sickle cell disease, and I wouldn't particularly have thought of that as a risk factor for sepsis myself, so that was interesting to me. So I'm just going to tell you a little bit more about some of these deaths. So the early pregnancy, that's before 24 weeks. These are the ones which are either septic miscarriages, termination of pregnancy, or prolonged premature rupture of membranes. One of the things that concerns me about this is these 2 groups in particular. I think we're very good at just letting the most junior people in the hospital deal with those. They go onto acute lists, they get done by the SHO. They're simple sort of surgical procedures. And yet they can be very, very sick, and we have to make sure that these people have the skills to pick up the ones that are sick and flag them up and get senior involvement very quickly. And the main message of this was that we must encourage everyone to use the antibiotic policies. There are policies for septic miscarriages, all miscarriages and for terminations of pregnancy, and they must be used. And some of these deaths were where the antibiotic policies haven't been followed. So the next group is before delivery. That's after 24 weeks, but before delivery. And this was really where your group A strep came in, this bug that's endemic in the community. And it's very common in children, and almost all of these women, all but one, either had young children or worked with them, and it is thought that this is where they acquired the bug. And this is why there was this recommendation that they wash their hands before and after going to the loo, because what it's thought is it's on their hands and they transfer it when they go to the loo, and then it's an ascending infection. And the vague initial symptoms are there. Now, I'm going to just read you a couple of vignettes, because when I go to the report, I always find these very marked, so I think hopefully you'll find the same. So this is one of these women. No, that's the anaesthetic one, that better wait. No. A woman in mid-pregnancy called an out-of-hours GP as she was feverish, shivery and unwell and had a sore throat, but was diagnosed as having a possible viral infection. No criticism there. However, a few hours later, the GP visited again as she developed constant abdominal pain associated with vomiting, greenish-black diarrhoea and reduced fecal movements, but no vaginal bleeding. The GP suspected a placental abruption, and although she was rapidly transferred to hospital, on admission she was critically ill with marked tachycardia, breathlessness, cyanosis and confusion. The correct diagnosis of septic shock was quickly recognised, fluid resuscitation was started, senior consultants were called, advice was sought from haematology and microbiology consultants, and appropriate intravenous antibiotics were commenced immediately. Despite intensive life support, she died a few hours after admission to hospital. And that was somebody who's just had a normal vaginal delivery and been sent home. So this is what we're dealing with, something that is absolutely catastrophic and needs to be recognised and picked up very quickly. And there was no criticism made of anyone in any of that care, but that is what can happen. Of course, if a woman's that unwell, the baby's not going to do very well either. And of these 9 women, there were 5 fecal deaths. What's really surprising is that any of the fetuses survived, I think. And it's highlighted that there's a risk of postpartum hemorrhage with these women as well, because they are very susceptible to having an atonic uterus. And one of them died of a combination of sepsis and major hemorrhage. And on the whole, all of these women had intact membranes, and yes, what I said before was about them having had a vagina delivery. I was wrong, sorry. These are ones that were before delivery, and they had intact membranes, but they still got this severe puerperal sepsis. So these are the ones after vaginal delivery, and these were the ones that were completely uncomplicated or possibly a second-degree tear, and went home as you would expect, no problems expected. And this was our old friend, Group A strep again. And the women had gone home, they sort of expect to feel a bit crap, don't they? Expect to want to go for a lie down. But, you know, some of these women, they were just very, very unwell. And part of this is about educating women and educating people in the community, the GPs and midwives, that this can happen and people need to be aware of it, really. One of the things I picked up was that low abdominal pain and diarrhoea were particular features of when they presented, and that's something you need to think about. After surgery, this is after caesarean section, most of these were already unwell, and that's why they had their caesarean section. And they'd often had prolonged rupture of membranes, and again, antibiotic policies are important here. And remembering that post-operative care is very important, because occasionally these women were unwell on the wards and it took a while to pick up on that, and so news charts are what's wanted. There was the one case of mastitis, which I haven't got anything to say on except for very tragic, and it can happen. So for these cases, I think it's early diagnosis and aggressive treatment that is the key. And this back to basics chapter that's been referred to is very important, because it is likely that these people are going to come up in contact initially with either a midwife, a GP or a junior doctor, and so we need to make sure that they're very much aware of these skills. So what are the signs and symptoms of sepsis that were particularly highlighted in the report? Well, pyrexia we all know, but it was highlighted that hypothermia is sinister. I think as anaesthetists we're probably all aware of that, because we know that that's one of the signs of sepsis, but it may be that other professional groups aren't so aware of that. Persistent tachycardia and tachypnea over 20, which they say in the report is sepsis until proved otherwise. This was pretty consistent. These women with sepsis were tachypneic. A low white cell count, again, is sinister. And diarrhoea and severe lower abdominal pain were features that often was to be seen. That's a picture of a Muse chart. And I think probably most places have these now, because it was a big lesson from the last inquiry What I'm less confident about is that we use this well in our hospital, and I think there's probably a lot of work to be done to make sure that actually all women do get charted on this, so that as soon as they enter the red, it's flagged up that they're unwell, because it's very easy not to pick up if they're just seen infrequently. So there should be antibiotic policies for terminations, miscarriages, elective sections and ruptured membranes. I understand the Royal College of ONG has produced such guidelines, and so each hospital should have their interpretation of that. And the use of early, aggressive, broad-spectrum antibiotics is essential when you're sick. This isn't a time to say, oh, no cefuroxime, as someone on each elderly care ward might get diarrhoea. This is time to get over the antibiotics. Other things, it was highlighted that there had been some situations where people have been slow to call critical care or anaesthesia. And this was particularly important because the fluid balance can become quite a minefield, with people obviously very easily going into pulmonary edema. And so contacting critical care colleagues early is important. Okay, so the anaesthetic deaths. There are 7 of those, which is about consistent with the last couple of inquiries. And they're quite a mismatch, really. Anaesthetists, however, are involved in 49% of all those who die. So I hope that is because when they're critically ill, they get us involved, rather than we get involved and we kill them. But I think that's what's meant by it. There are no big themes, really. The only main thing is the failure to ventilate lungs, which obviously is something that's been in other confidential inquiries. So I'm just going to go a bit more into detail on 2 of these. First one was on ITU, and a tracheostomy was dislodged while turning the patient. This patient was a known difficult airway, and there had been no plan documented for what to do if the tracheostomy became dislodged, and the intensive care was being looked after by a very inexperienced anaesthetist. So it was felt that there could have been improved care in this case, that there should have been a definite plan, and that's clearly a tragedy. Then there was another case, which was failure to intubate and oxygenate. And I'm going to read you the vignette for that one, to make you all go cold. The anaesthetist failed to stop trying to intubate the trachea, even though oxygenation was achieved through an intubating laryngeal mask. Failed intubation guidelines were followed to an extent in this very stressful situation. But esophageal intubation through the intubating laryngeal mask airway was not recognised, and further hypoxia occurred. The woman was coughing, but was not allowed to wake up, and a second dose of thiopental and a long-acting muscle relaxant were given, even though the end expiratory CO2 indicated that the woman's lungs were not being ventilated. Cricothyrotomy was not attempted. So although we do know what a failed intubation during obstetrics is, it is clear that it is not always followed. And what was particularly commented on here were that there were persistent attempts to intubate rather than bailing out, and clearly what they should have done was stop trying to intubate, focus on oxygenation and wake the woman up. A second dose of thio and sux were given. Oh no, it wasn't sux, actually it was long-acting muscle relaxant. But again, you know, that is something that is generally considered a no-no in these failed intubation situations. And there was a very definite fixation error amongst the team, that they became very, very focused on getting the tube down the windpipe rather than on anything else. So from these 2 deaths, so it's to say that airways remain a core skill, that must be rehearsed, and I think needs to be rehearsed at every level, because there wasn't an indication in the second case that it was particularly because of junior anaesthetists playing around. It was that people came in and then wanted to do their bit of kit or whatever, which is a classic, really. And non-technical skills are very important, and they're getting more of a priority in training now, and that needs to continue to happen. And things like the World Health Organisation checklist should be good at trying to make sure. I'm sure that in this situation there was someone else in the room who was thinking, should we just wake the patient up? But clearly no one said it. They kept trying to get the tube down. And, so all these things about enabling the team, increasing communication, and that I think are very important. Now this second case, the one with the unable to get the tube in, led to what was quite an interesting recommendation actually, because this woman had a working epidural in, and they were going to wait till they got to theatre to top it up, and it then became a grade 1 section. And so the recommendation is that if they've got an epidural in, you should top it up immediately. Now, when we went to Manchester to see this presented, everyone accepted that quite all right. But my understanding is when it was presented in London, there was quite a hoo-ha about it. And there's no doubt that there are places in the country where it is felt that topping up an epidural in the room is substandard practice and you should be in theatre with full monitoring. So I'm just going to that. The recommendation from this report is that you do top up as soon as possible in the room. And so I'm just going to say what the pros and cons are. The pros, obviously, are that you get it topped up quicker and hopefully reduce the need for a general anaesthetic, particularly if the clinical situation changes to a grade 2 becomes a grade 1, which is what happened in this case. However, the cons are that if you top up in the room, you are inducing anaesthesia because you're changing an analgesic epidural to an anaesthetic epidural, and you're doing it without monitoring, without an anaesthetic machine, without airway equipment, without a trained assistant usually. And if you do that, clearly mustn't leave the patient if something else happens. You can imagine the situation, you just started topping up, you give them 20 mils and then caught prolapse down the route. You can't do that. You started an anaesthetic on this woman and you have to stay with them. Now I think this is for your own department to decide. In York, we do top up in the room and we've got no plans to change that on his advice. In fact, the advice is right. But I think it's very important that people realise that it does have some risks with it and the anaesthetist needs to stay with that woman, be aware of what they're doing. But apparently there was quite a hoo-ha in London. Other anaesthetic deaths? Well, they're a right mix. I'm just going to whip through them very quickly. There was a probable aspiration of gastric contents at extubation, and clearly that shouldn't happen. So extubation should be done awake. The one thing that was recommended is that we should decompress the stomach if someone's had a recent meal. And we certainly used to do this. I remember doing this at Jimmy's, and whilst they were asleep, you put a big tube down and suck it out. Do any units still do that? No, we certainly don't. But it's recommended here. If there is evidence that they've recently eaten them, we should. So maybe that's something to think about. There was another death from something rare called leukoencephalitis, which is an acute hemorrhagic disseminated leukoencephalitis. It's very, very rare. It's an autoimmune disease where there's a cross-reaction between the myelin and something or other. And basically, it's not very good. The relevance of it is that it's been put in the anaesthetic corner as being one of our deaths because there was also an empyema of the cord, and they feel that that may have triggered this autoimmune process. And so the emphasis is made that any neuraxial block must be done under strict aseptic technique. And I would hope everyone does that anyway. There was a case of opioid toxicity with PCAS. That shouldn't happen. PCAS shouldn't malfunction. That is assumed to be what happened, though of course there are other ways this woman may have had excess opiates in her blood when she died. But unfortunately the PCAS was just taken back and put back into the pool of PCAS machines, and the drugs were chucked away, so they could never actually confirm what the problem was and why she died. It is assumed it's a PCAS malfunction, but they don't know. IV stintimetrin was given at termination in someone with an IV drug user, who was an IV drug user, and it is thought that that caused a cardiac arrhythmia and death. Again, that was an assumption from a post-mortem, but the post-mortem was fairly vague, and comments were made about improving post-mortems to try and do that. Sorry?
Why is it anesthetic?
Because they gave stintimetrin. But you have a point. I think that's mine, really. And there was another death which was blood transfusion incompatibility, they think. It was somebody who died fairly rapidly, having had lots of loin pain and all the rest of it. But again, there wasn't enough evidence around to make these diagnoses. So 4 out of these 5 have been a bit vague, really, and that's because kit wasn't kept, the crime scene or whatever wasn't left as it was, and post-mortems were inadequate. And so recommendations have come out of all of these to make sure that doesn't happen, because it's clearly of use to everybody that we learn from all these deaths. And, you know, if that was a PCAS machine malfunctioning, it'd be nice to know, wouldn't it? It'd be nice to know what make and things like that, exactly what was malfunctioning. So remember to do all those things. So yeah, in 4 cases, 4 of them, the diagnosis was in doubt. So we were asked to keep all equipment or drugs, etc., if there's an incident. There's a need for appropriate post-mortems, and there is a recommendation that these get done by specialised obstetric post-mortems order. And that there's local serious incident reporting of all of these cases, so that lessons are done locally quickly. So, I won't really go into hemorrhage because we're getting near time. And there was little in the hemorrhage that was new from previous ones. All the lessons to be learnt were the same ones that have been put out in previous ones, really. The importance of protocols and skills training, senior involvement early, guidelines for those who refuse blood, that all previous sections have their placental site located, that there are meows charts for at least 24 hours post-delivery, and that women with placenta previa who bled are inpatient from 34 weeks onwards. So there's nothing new there. It might be the odd controversial thing, but that's it. So I'm not going to go into that in any more detail. So I did decide I'd pick out which of the 10 recommendations, because there are 10 top recommendations, are relevant to our anaesthetists. I'm sure it won't surprise those who know me to know that all 10, I think, are, because we're obviously the centre of the labour force, so they're all relevant to us. And I was going to go through them in a bit more detail, but I won't, because that's already been done. And so I'll just flick through those and say thanks. But my biggest advice is to go away and read it, because it's easy to read, it's interesting, and I think we all have lessons to learn from it. Okay. Thank you.